I wanted to make the world safe for academic facial plastic surgeons. In other words, we were kind of thought of as the black sheep of the otolaryngology family because we didn't really do good science, and everything was about showing pretty pictures.
Welcome to the second episode of the Rhinoplasty podcast. I am so excited for our speaker tonight. He's brought us through the generous sponsorship of this first month from Medial, who make Medicon instruments in South Africa. And the first time I met this man or listened to him speak was more than 5 years ago over in America, and I was blown away by a few things. The first thing was that he was so scientific in what he did, because often people just speak about, oh, in my hands, this is the results. But this was someone who wasn't interested in that. He really wanted to teach, and it's a passion for teaching that has led me to invite him to be our second guest. He also is very intricate in the involvement of the evidence-based research and Rhinoplasty Group, and it's a great honor and privilege to have someone who's come all the way from California. Sam Most, thank you very much for being a part of this talk.
Thank you very much, Cameron. That's very generous of you to say. I have to say that I remember meeting you a few years ago at a meeting. I think it was through Dr. Jeff Marcus also that we personally got to meet. And I've been thoroughly impressed with the energy that you've brought to the rhinoplasty world in the past year. And it's just really incredible everything you've done with Rhinoplasty, World Rhinoplasty Day, and to have the energy to do this. I really give you kudos for that, and thank you very much for having me.
Great. So Sam, I want to kick off. Now, we're sitting in South Africa. So my first question to you is, you're the chief of facial plastic surgery in Stanford. How many residents are studying otolaryngology at Stanford?
We have 5 residents a year studying otolaryngology right now. Our program is really quite large by standards here in the U.S. That's about, I think, the maximum of any program per year. And it's a 5-year program. So I guess there are about 25 or so residents.
And is that 25 residents in total for the entire otolaryngology degree?
Yes, at Stanford.
So that's quite something, because in South Africa, we're less than 50 in our whole country at 8 different universities.
Yeah, a little different.
So tell me, Sam, how did you end up where you're at?
Do you want the long story or the short story?
I want the interesting story. How do you end up being a professor at Stanford University? That's just amazing.
Oh, I try not to take it for granted, and I think it's really an incredible environment to be in. I did my medical school training here too many years ago. And then I went off to Seattle to do my training in otolaryngology, head and neck surgery, and then facial plastic surgery. And I was fortunate also to be hired at that point, really young, right out of fellowship, as a division director in facial plastic surgery, just how the timing worked. And about 4 years later, after I was on faculty there, we had a new chairman start a new department here at Stanford in otolaryngology. And I was recruited back to come and sort of build a facial plastic surgery division that covers the breadth of reconstructive and aesthetic surgery that we had at University of Washington. And it's really been just gratifying to see how the whole department and my division's grown.
Yeah, I tell you, I'm glad you say you don't take it for granted, because we actually share a little bit in common in that it's actually my 3-year anniversary from when I nearly passed away from septicemia. Mm. And I know that about a year ago, you got really sick with COVID.
Yes. Yeah, I'm not so sure it compares to what you've been through, Cameron. But it was probably a week from now is about when I probably was exposed. And at that time, there were probably 10 cases in the Bay Area of San Francisco. So it wasn't something we were really too worried about. There were no precautions. The whole world was wide open. Nobody, so if you think about what we do, looking at people's faces and things without masks, it's a high risk thing. And we never found out how I picked it up. But it was, we're coming up on a year soon for my hospitalization. And it was a harrowing experience.
Well, we're all very happy that you're back and you're stronger than ever before. And you're adding so much more to the rhinoplasty world. So before we climb into a bit more of the rhinoplasty stuff, one more question. I follow you on Instagram and you do a lot of reconstructive facial plastic surgery as well.
Yes.
I think sometimes we get very focused on just like rhinoplasty and facial plastics. Tell us a little bit more about what you guys get up to.
Well, another passion of mine is to do skin cancer reconstruction, in particular forehead flap surgery. And it's sort of related to rhinoplasty in a way, and sometimes I post about this. I think that really it makes you a better rhinoplasty surgeon to understand how to reconstruct the internal lining and the framework of the nose as well as the external lining of the forehead flap. And so I continue to have a passion for that. And the other skin cancer reconstruction around the face requires a certain amount of creativity, which I find stimulating, and there's a lot of gratification from the patients as well. So I really enjoy doing that work. It's a great thing to do.
Yeah.
In addition to that, I just want to also point out, in addition to that, one thing, it's the 1 year anniversary is passing right now for our annual mission to Cambodia, where we do reconstructive microtia surgery and cleft lip palate surgery as a team. I don't specialize in cleft lip palate, but I do microtia too out there, and so it's something we missed this year because of COVID, and we're hoping to do again about a year from now.
Yeah, I really hope that happens for you. I also notice you love being outdoors with your dog. What do you get up to when you're not doing facial plastic surgery?
Well, right there, up over my shoulder, there's a fish. I don't know if you can see it. A couple of salmon and some actually net frame or some flies that I tied myself. I really enjoy fly fishing, and so when I'm outdoors, that's what I really like to do. But really spending time with my family and, of course, my dog. You don't see pictures of my family on Instagram much because I don't like to post that. But you see lots of pictures of Jerry, the German Shepherd.
Yeah. Well, we're going to have to get you out here to come fly fish with me because I also love it.
Oh, really? Okay.
Yeah.
We'll do it.
Okay, so Sam, let's talk a little bit about the listeners who are potential patients. If I could ask you for maybe the 3 most important things you like telling patients pre-operatively in terms of rhinoplasty surgery.
The most important things, I think, are to first be able to communicate with your doctor about what you're interested in, and have some sort of concrete understanding of what you like. It's not possible to go down to the millimeter and guarantee things, but if you don't understand each other in terms of what your plan is and communicate well, then you shouldn't proceed. Doesn't matter how great the surgeon is or how great a person you are as a patient, that communication has to be there. And sometimes it just isn't. Secondly, for everybody, you always have to think about the limits of what can be done surgically and the impact it can have on breathing. So, not everyone's nose can be changed into something that you see on Instagram or social media or what have you. It's just not possible all the time. And finally, I think that for patients, just having realistic expectations is really important. And that sort of falls on both parties. They really, I really feel like I need to always do a better job communicating and make sure that patients understand what's possible and what isn't.
Awesome. Well, Sam, I want us to dig into some rhinoplasty topics. I'm very excited about the 3 topics we're going to cover tonight because it's really something I want to incorporate in my practice is this structural and preservation rhinoplasty and how to marry them, and then also evidence-based medicine. And I want to talk later when we get to the patient-related outcome measures and questionnaires, because it's something that I've been playing around with in the practice. But I'm going to ask you to share your screen and then climb into the first topic that you want to chat to us about.
Absolutely. Okay.
So Sam, whilst you're getting that ready, on an average week, how much time do you spend in theatre and how much time do you spend consulting?
There, we're ready to go. On an average week, I will spend about 2 days in the office doing consults and 3 days operating.
Awesome.
Okay, can you see this? Is this showing up?
Yeah, that's perfect.
Okay, great.
So I remind you that as there quite a few people might not be watching it on YouTube, this is going to be more difficult. You're going to have to try and imagine this is just a podcast, and so describe maybe some of the slides, but I'll chat as we go along as well.
Absolutely. Okay. So for our first topic, I thought maybe we should go ahead and start talking about different ways of doing dorsal hump reduction. I think for potential patients out there, so they can understand what we're talking about when we say dorsal preservation and preservation rhinoplasty versus Joseph reduction rhinoplasty, and when and how to choose potentially which way to go. This is more, that would be more for the surgeons out there. I can be found at these, on Instagram and Facebook, primarily Instagram, if people have questions. And, the first thing I want to really point out is I'm not going to really take credit for anything you see or hear here, because these concepts are well published and have been around for many years. I'm going to talk about some things, some modifications, and perhaps some ideas that I have. But I think that credit needs to be given all around. And these are two potential references. This Preservation Rhinoplasty textbook by Daniel and Chekier and so on is good. And this recent issue of Facial Plastic Surgery Clinics is also excellent for this. And there are a couple of papers you can get to if you want that talk about the specific things I'm talking about. The one on the left in Facial Plastic Surgery Aesthetic Medicine, which is an excellent journal, and of course I'm biased as an associate editor, is free download. It's open access. We made it that way so you can have access to it if you want. So again, I want to give credit to my colleagues who brought me along in this regard, because I've really only been doing this procedure this way for about a couple of years now. And the first time I heard this idea of dorsal preservation, it wasn't called that. It was called the letdown versus pushdown operation. It was Fausto Lopez Ulloa and Jose Montes Brachini, Mexico City, talking about it in Portland in 2003-04. And I thought it sounded like the craziest idea. I'd never heard of this. I didn't know any history behind it. But in the last few years, it's had a resurgence in many ways, because people like Olivier Gerbaud in France has brought along piezo use, ultrasonic saw use, and rhinoplasty, full open bony work. And Yves Saban has been doing this method for his whole career in France, and Boris Chekier picked it up in the last 8 years or so and sort of began popularizing it again, and my friend Goxel in Istanbul as well. So I want to make sure that I give credit to all those guys. And this idea of preservation rhinoplasty is a term that was coined by Roland Daniel in his efforts to sort of repopularize it, if you will. And it refers to preservation in potentially 3 different areas. This is an image taken from his paper with Aaron Cousins. It's a Venn diagram showing PRD, which is preservation of the dorsum, PRS, which is soft tissue skin envelope, SSTE, or the ala, the alar cartilages, which is PRA. So full preservation would mean preservation of all 3 of these things, whereas dorsal preservation is just the one. And that's primarily what I do, as well as alar preservation, which, as we'll talk about, is something that we've been doing for about 12, 13 years. So just to give a little history for those of you who are beginners or perhaps just patients out there, this idea of preservation of the bony cartilaginous vault, or osteocartilaginous vault, which is this whole big structure of the nose, is an old idea. It goes back to the very beginnings of rhinoplasty at the end of the 19th century. And the first publication in that regard came from Goodale. These sort of grainy photographs show a 4-month post-op here of a patient who had a hump takedown with this idea of a push down, which, so just to kind of help people visualize what we're talking about, I'll get into the diagrams a little bit. We're talking about moving the nose backwards into the face rather than cutting the top off, which is a different way of doing things. In 1914, Lothrop, also in Boston, as Goodale was, described a similar version of this, where he resected bone posteriorly and moved the whole nose inward. So these publications are out there, and it was Maurice Cottle, who's a famous otolaryngology / rhinology / rhinoplasty surgeon, who in the mid 20th century kept this idea going of doing the surgery that way, versus Jacques Joseph, who actually an originally orthopedic surgery trained a person who became sort of the father of modern facial plastic and plastic surgery, did another way of hump takedown, which is to take the top off of the nose and then move it sort of medially. And so I'm going to show this diagrammatically, and for those of you who don't have video, I'll try to describe what I'm showing here in these slides. But what we have here, the top right, next to Joseph's picture, is a diagram of a nose and a cross-section plane showing what we're looking at in the center of the screen, which is sort of a pyramidal structure with a strut going down the middle. You could also think of it as a sort of a Roman arch with a central post. And when you do a Joseph hump reduction, what you do is you basically take the top off, as shown here in this diagram, just showing the top being cut off. And if you imagine that you took the top off of a pyramidal structure, you'd end up with a flat top. And depending on how much you took off, it could be much wider. And so you couldn't just leave it like that. It would look kind of odd. So you have to make some cuts. We call them osteotomies. Medially, which is sort of towards the middle, and laterally towards the sides of the nose. Break the bones, and then you have to move them towards the center to get, once again, a narrower contour across the bridge. And this was the way it was done for many, many years, and the Joseph School kind of became the dominant school in the United States. And it was in the 1970s that Jack Sheen realized that complications arose if you do not reconstruct the mid-vault, and that's shown here in this diagram, showing the top of that pyramid where that Roman arch is, putting a couple of spacers, if you will, called spreader grafts to make that look more normal and also preserve the ability to breathe. So how does that differ from preservation? As I said, preservation is really kind of moving the whole thing backwards into the face rather than cutting the top off. And in this diagram, I'm showing where this red line is, kind of shows where the cuts would be around the bone, and the arrow points into the way you would impact the dorsum into the face. And the difference between a push down and a let down is in a push down, if I say that, we're not resecting any bone, we're just moving it into the face. So you can imagine the bone overlaps, versus in the let down, you remove some bone, as shown in that dark red area, and then it just kind of settles into position. So those push down and let down operations are the two main ways of dealing with the bone, and those haven't changed much. But there are some variations in the way you address the septum. And the original method by Caudle is shown here diagrammatically in a diagram drawn by my artist, Chris Kralik, who's really outstanding. And you can see here, and it's difficult to describe to those who aren't watching this, just listening. It's sort of like you're cutting a section of the septum and rotating it forward and down and pulling the top down with it because it stays attached, if you can imagine that. And so the shaded areas here are what we remove, and then this cartilage rotates forward. This is actually a video of a cadaver dissection with the nose opened up so you can see what's happening in this. The lab dissection was actually done by Valerio at the Rhinoplasty meeting in Istanbul, and then I played with the specimen afterwards and did this recording myself. So those are my hands there. But just showing here this is how it works. You pull that septum forward and push down on the dorsum and flatten it out. A couple things to notice is if you look just underneath my finger there, there's a step off. That's one of the concerns you have with this technique, right at the radix. So you want to try to avoid too much drop there. And when you pull the septum forward, you end up with extra length and there's tension on it, so you need to secure it to the nasal spine. The Saban method, which is sort of Goya's method, is just to resect right underneath the dorsum on the septum, directly underneath it, to scrape it off and then push it down. And this is a cross-section here showing that. Now, in this case, you'll notice that we're not taking the top off of the Roman arch, we're actually keeping it. And that is probably the central concept, I think, of the advantage that I'd like to say is the difference between these two techniques. That, if you imagine the strength of a Roman arch, it's that upper part, the way those pieces fit together. You're not disrupting it. You're actually just keeping that and moving it back into the face. And so the push-down operation will look like this, and you can see here there's some overlap of bone, which can get into airway issues, as we'll describe later. versus a let-down operation. The same thing happens to the septum, but the bone is resected at the base and the whole thing drops down into position. And so that is actually has been shown, at least in our cadaver studies, to have a better result for airway preservation compared to the pushdown. Do you have any questions about all that?
No, it's very well explained. Excellent. I'm very interested to see what the indications are, but I also want to know what are the do not attempt this in this type of a nose.
Yeah,
so
we're gonna. I thought we should talk about that a little bit. Of course, this is also a big topic, but I'll talk about some generalities here. The things you need to really do are profile analysis, profile type, which we'll talk about, and bony vault length. And on the frontal view, really the key is dorsal static lines and dorsal width and presence of asymmetry. And if it's asymmetric, how is it asymmetric? And is it something that will be advantageous or disadvantageous to do with preservation, dorsal preservation? And so this is a picture of my patient, but I'm adapting this from one of Carlos Neves' slides, which he showed very nicely. I think the key areas to look at are, in profile analysis, the radix, depth of the radix, the keystone, width, symmetries, any issues there, and then the super tip, if there's a big drop or not. And there are two main types of dorsums that preservation rhinoplasty surgeons sort of talk about: V-shape versus S-shape, which is, it's somewhat arbitrary, to be honest with you. I think the things to think about are if the radix is very deep with a very acute angle at the hump, or whether it's more S-shaped, like a deep curve. Let me say that again. I think the key things to think about are whether the radix is very deep, which sounds like it ought to be a V-shape, but it's really more S-shaped because of the depth of it, and that's shown on the right, versus a V-shaped gentle curve without a really deep radix. And so, as I said, these are somewhat arbitrary, and so I think that some other factors come into it in terms of how you judge whether or not patients ought to have this done. Bony vault length is a key indicator, I think, and patients with shorter nasal bones, as shown on the left side of the screen, are probably better candidates because there's more cartilaginous flexibility when you do this procedure and less bony flexibility. So if the bones are very long, such as in the patient on the right, really not a great person to do complete osteocartilaginous preservation. And this is shown kind of in this nice slide from Aaron and Rollins' paper that I mentioned earlier, where they did ultrasounds. And you can see here that they're at the radix osteotomy site on the right side of the screen. You can see that there's a drop-off. And so this is hidden by the thick skin. So you don't really completely flatten that curve. If you look at the curve of the dorsum on the left and the curve on the right, it is not completely flat. And so if you have a very acute angle, you're not going to be able to flatten it enough to get rid of that. And you know, one of the main complications of dorsal preservation rhinoplasty that's cited by authors such as Saban and others is hump recurrence. It's probably not recurrence as much as it is just it's still there. It never really went away, and the swelling sort of hid it for a while, and it shows up over time. I don't think it's really springing back up, but who knows?
But that also is quite common. I mean, I've seen quite a bit of that on our WhatsApp groups and things about the Joseph technique, where there's still a hump left behind.
Oh yeah, no. To be fair, you know, when I look at my results for Joseph hump reduction, and I tell patients, it's really rarely straight as an arrow. You know, it's usually there might be a little irregularity. So I guess I'm not talking about little irregularities. I'm talking about really true, like a hump still being, like a decent size hump still being there. I think that's what I would consider a complication. In fact, one of the patients I'll show you later, if we have time, is somebody who has a little bump there, but it's much improved, and you know, I don't consider it a hump recurrence at all. And so these are some examples of what I would consider ideal profile types for dorsal preservation rhinoplasty. So they're high dorsums with gentle curves, without a really deep radix, and without a large supertip break, because the supertip also can drop a bit. And so these folks are all good. And from a frontal view, you should look at those dorsal aesthetic lines. And for example, patient on the left has a nice width, has nice dorsal aesthetic lines. Patient in the middle has a twisted nose, which is a midpoint deflection between the bone and the cartilage. versus the person on the right has a deviated nose, straight deviation though. The bone and cartilage are in line but just pointed in the wrong direction. Now, out of these, I would say the one on the left and then the one on the right are potentially good candidates for preservation. But the patient in the middle would not be, because you don't want to preserve that. You want to actually fix that with an open technique on the dorsum. So that wouldn't be a great candidate. And this is the study that I was mentioning earlier. And we did this small study, and it's actually been cited quite a bit, which is sort of gratifying. But it was really just to look at whether or not we could do dorsal preservation methods sequentially in the same cadaver specimens and look at CT scans. And so we took some heads and we did a push down and then a let down operation in the same patients with CT scans in between, I should say specimens, not patients, and looked at the airway. In addition, we compared it to some matched cadaver specimens where we did traditional autospreader flaps and so on. So in those specimens, we saw no difference in the airway between the let down operation and the autospreaders, showing that there's really equivalence in terms of airway preservation. But the push down actually was much tighter. And so we recommend against doing the push down operation if it's avoidable in patients, and actually just taking a little bit of that bone out so that there isn't any impaction of the airway. And this is just showing kind of the results that we got with that. So with the push down, when you have decreased internal valve area, the let down and Joseph, the areas were stable.
Very interesting.
So do you have any questions about indication and so on?
So no, it does. The twisted nose was the one that I wanted to know, that we wouldn't be able to do that. And the straight deviation is interesting, because if you're going to bring it down, you still have to straighten it out.
Yes.
So I'd like to know how you get that right.
Okay. All right. So let's talk about this concept of structural and preservation rhinoplasty combined. And this idea, again, I don't want to get into any hot water by trying to claim this is something that I thought of. It's really not. It's not at all. This has been done worldwide by people like Occult, Cousins, Ferreira, as you mentioned, Miguel, Carlos Neves. Milos is doing it now. Ishida in Brazil has been doing a variation of it, and others. And so, I'm just going to talk a little bit about my experience here and with structural preservation rhinoplasty. And so
I've got all these guys lined up over the next couple of months.
Fantastic,
so
fantastic. So, for me, my definition is, looking at the dorsal preservation and alar preservation is one thing, and combining it with structural tip tripod work that we've been doing for years and that I feel very comfortable with. So, again, our tripod concept for novice surgeons or for patients is the idea that the tip of the nose is supported on a tripod that includes the medial crura, which is the part between the nostrils and the columella there, and then the sides, the lateral crura. And if you think of it as a tripod, it's actually quite intuitive to think about the manipulations you can do on the tripod, such as advancing it forward, rotating upwards, and so on and so forth. The modified subdorsal strip method that I use is a modification of the septal techniques that we talked about earlier. In some ways, it's sort of like a modified caudal. And what we do with this is we leave a subdorsal strut or strip of about 5 to 6 millimeters rather than cut right under the dorsum. So it's a substantial strip. Gives you some control on it. We put a flexion cut in it, which is, again, an idea that Fausto and others have been talking about for a while with their methods. And it allows it to flex into position. Our osteotomy at the top osteotomies are the same as we described earlier. And the whole segment flexes down, and you have to trim it a little bit, of course. You can trim it to the level you want. And then suture control with PDS sutures is done to kind of hold it in position. And again, this is something that I came up with after having watched some people do this for the last few years. And I started doing this about 2 years ago. And just to show that, by the way, you can also remove some cartilage as shown here for your septal extension grafts and so on. But this technique is a modification of a lot of different things that other folks are doing, as I'll show you in a minute.
So can I just interrupt you for a second there? So are you doing this as an endonasal or an open approach?
Totally open. So I'm doing open structural
Totally
rhinoplasty.
But you're going to be dissecting on the tip. You're going to stop at what Miguel calls the W area, just the start of the upper laterals, and not touch that.
Yeah, I take it down about 5 millimeters. The W area is just is not a cartilaginous attachment, really. It's just a membranous area. So I just open that up.
Okay, but you won't actually, you just go cephalically maybe 4 or 5 millimeters and stop there, and then you bring it down.
Correct.
Okay.
Correct. Just to see. You don't necessarily need to do that, but you can easily do that, and then it gives you can actually reattach those very easily if you need to. So the cartilaginous and bony resections and the letdown are kind of shown here, comparing the modified subdorsal strip with the Saban and the caudal method. This is how they drop into position. And again, I just want to point out that lots of people have variations. This is Carlos published this after our paper, but he was doing something similar, and I was aware of it actually because we chatted about it when I was talking about the way I was doing things a couple of years ago. And there's a slight difference here because he's actually not keeping that entire caudal strut intact. And subsequent to this, he published a paper called the Tetris Method, which is also kind of similar to this method that I'm talking about. So, there's a few of us having this idea of keeping the subdorsal strip intact, putting a split in it, and dropping it in position. But for me, the key is keeping this caudal strut intact, which is different than what you just saw. And independent, this is all came up with this completely independently. But you can see we're all kind of going towards the same thing. And what this does is it allows us to do our tongue and groove method or other suture control methods on the tip that I really like with an intact caudal strut or septal extension grafts or what have you. So this to me is, for my practice, the key part of this. And you can't do this with the caudal method. And the Saban method cuts all the way through the anterior septal angle as well. This having suture control on that little strip there is also something I really like. So this is one of the first cases that I did about 2 years ago. And just analyzing her, she has a nice tip. It's a little bit over projected. She has some facial asymmetries. You can tell the right side's a little shorter than the left. She has a little bit of dorsal asymmetry, and the left tip defining point is more prominent. But those weren't issues for her. She really just wanted this to be, to be straight. And so I did this modified subdorsal strip method, and we dropped it in position as shown here. And on the diagram, for those of you who can't see, is showing that cross section again, keeping that Roman arch intact and dropping it in. And that's again a key point. This is showing you just that little W area separated very slightly. You see that? There's just about a 4 millimeter. The whole rest of the cartilaginous dorsum is completely intact. And there's this initial cut down and then back. And this is a little video showing that strip coming out. And you can take out a little more if you want as you go along. This is, again, just showing that. And then now you can flex it up, and now you can see. You can even actually put it back up a couple of millimeters if you think you cut too much, by the way. You can set it up, which is another part of the control of this that I like more than the Saban method, because if you cut too much there, it's pretty much you're done.
Yeah.
So this is.
And then what do you use for the bone? Are you using piezo to have this let down? Okay.
Yes. I do a complete piezo open dissection. And I have a short video of that too I can show if we have time. I didn't want to take too much time, so I didn't initially include it. But
you've got all the time in the world. This is fantastic.
You'd like to see it?
Yeah, no, carry on, Sam. This is really great.
Okay, great. So this is showing this PDS suture going in position. This is where I wanted the dorsum. Now, you see there's a big step to that caudal strut. We're going to trim that. This is showing the side view. I like doing alar spanning sutures and other things. Tebbets and others have championed over the years to get really good control of that tip. And so I like having that sticking up. And so this is what this operation looked like on our Gunter diagram afterwards. By the way, it was this operation, her is one of those ones like that perfect golf shot. The whole operation took about 64 minutes.
Wow.
Which is what, it happens once in a while. I wasn't rushing at all, but you didn't really need to do much tip work, or any. So
that's very interesting, because I wanted to know time-wise, compared to a Joseph open approach to taking off the roof compared to doing your preservation. Have you found a difference?
I think it's a little bit slower doing the open piezo takedown just because there's a bit more dissection and setting up the piezo and using it versus just taking osteotomes and going to town with the osteotomes, frankly.
Okay.
But it's not a big difference. I think, for me, most of my work ends up being around the tip anyway, spending more time there. But she didn't really need anything. I just put an alar spanning suture tongue and groove to support her tip where I wanted, and we were done. This is the on-table result. And, I'm not a big believer in on-table results in terms of showing them. I don't take a lot of these photographs in the operating room. I did that day just because it was one of the earlier cases, and I thought it'd be interesting to see. And you'll see that it holds up. Here she is at 1 year. And by the way, she's slightly deprojected, as you'll see on the base view. You don't appreciate it as much there. And here's her 3/4 view. Frontal view, you can see she's got some improved symmetry of that dorsum. The dorsum was completely intact. Base view, you can see here there's a bit of deprojection on her. And so this really, I like these views. They really show the contour along those dorsal aesthetic lines to the tip very nicely. And you can see that, we haven't touched that dorsum, but just settling it down to position, that transition in the lower mid-vault to the tip looks kind of nice, I think, the way it kind of just blends in.
Oh, it's fantastic for your first rodeo there, eh?
Yeah. Well, not the very first one, but one of my early cases. And
so, Sam, just tell me, I want to ask you quickly a question here.
Yeah.
Your photographs that you post and you use at talks, in terms of 1 or 3 or 5 year results, I think they're some of the most, the best that I see, because in terms of, do you have somebody who puts them together for you? Because they are absolutely identical. And really, I'm impressed, and I want to know how you do that, because I use Vectra's H1, I think it is, and it gives a result. But I don't know how you get this done. Please tell me about it.
Well, earlier on in my career, I was sort of the photography guy. I did all these instructional courses on photography and papers in photography for our journals, and so I it's sort of as a hobby of mine as well. And so I think it's just having standardized lighting and proper white balance on your camera and standardized positioning for the patients is really key. And honestly, I ended up taking a lot of these pictures myself. My fellow take pictures, one of my nurses takes pictures, and if I don't like them, I just make the patient get back in the chair and I take them again. because I want them to be when I look at these two pictures, I see that her head is slightly tilted on the pre, so that sort of bugs me a little bit, to be honest with you.
Yeah.
But I'm a stickler for that, so I appreciate you noticing that. Thank you.
That's awesome. Yeah.
And you can see this is an open approach. People always ask about these incisions and things. If you close it properly and take good care of it in surgery, they're really hard to see. You can't see that incision at all. And so we're going to talk about patient-reported outcome measures next. And one thing that I've been saying in the past couple of years is that I think we should all show data about the patient's breathing and aesthetic satisfaction after every single case that we show photos for is just as important. And so I'm starting to do that now for every case that I have the data for, because this problem that I'm showing you, we came up with 4 years ago. We don't have before that. So this is this problem, which the first 4 questions shown in light blue are highly validated for breathing, which is actually even more validated than the nose questionnaire, which everyone likes to use, which is now quite old. And then the bottom 6 questions are aesthetic, including a psychosocial question number 5, which is a very important one. And so you can see before surgery, she was concerned mostly number 7 and 8 scored 5, which is worse, for straightness in the shape of the nose from the side. She had a little bit of congestion and so on. And at 12 months, she goes to all 0s. And so, this is, again, more evidence that this is a patient whose breathing has been preserved and who's happy aesthetically. So I think that's an important thing to show. And I'm trying to get everyone to start using this problem. It's been adopted worldwide by multiple surgeons in multiple languages, and we'll talk about that in the next talk.
I'll use it for all of my patients.
Fantastic. And I hope, I'm not going to try to lead you on here, but do you find it useful just as a doctor, let alone not talking about research, but just before you walk in the room, you can look at that and what some of the patient's concerns are before you walk in the room?
No, it's essential. It's like Medial said to me, Cameron, if you don't take photographs, you didn't do rhinoplasty.
Yeah.
If you don't do a Schnoss questionnaire beforehand and afterwards, I don't think you should be doing rhinoplasty. So I've actually gotten I have an athletics background. I used to be an Olympic canoeist, and I'm very keen on the whole functional side of rhinoplasty as well. So I've been doing quite a bit of research with Prof. Martin Schwellnus at our big sports institute in South Africa, and also working with the International Olympic Committee. And I've been trying to develop a sport-specific type of a schnoss. So I've been comparing them to each other and trying to work out something that can help sports physicians. It's more a screening questionnaire than a prom for ourselves. But it's a bit more difficult than I realized.
Yeah,
I mean, what you guys have done is...
there's a whole science behind it. And that's going to be a little bit, I'm going to talk a little bit about that in the next little thing. So we'll talk about that. I learned a lot developing that problem, quite a bit. So I think this is the video you requested. So this is, of course, a sped up, shortened version showing the modified subdorsal strip. So this is the open piezo approach you're asking about. So we got full dissection of the entire bony vault. And, it's hard to get a camera in there, but this is showing the osteotomy and ostectomy there. And this you're going to see a little piece of bone coming out here in a second. It's important to do the medial cut and then the lateral cut on that ostectomy, Cameron, because otherwise it's mobile. There you go. So you can see a piece of bone coming out. There's a little separation we do at that point between the upper lateral and the bone to allow it to flex open. I'm not so sure.
Is that what Miguel talks about, the ballerina move?
Yeah, and honestly, that's been done for a long time. You see the slight cut there, the W area I just did. I'm going to pause it so we can talk about that. The ballerina, again, this is a little bit of Wild West stuff going on. Everyone's trying to claim everything, and people have been doing that little maneuver for a while, and then. My friends Milos and Guxel jokingly called it the ballerina maneuver, and but again, this stuff has been going on for a while. I think that Fausto has been doing it, and Carlos was doing that for a long time. But anyway, there's a lot of stuff going on out there, and I think I haven't done a cadaver study on that to see how important that really is in terms of flexion. I think that it's another important concern is whether it affects stability of the lateral nasal wall. And we actually just published a paper that came out in Facial Plastic Surgery Aesthetic Medicine this week showing that it doesn't seem to affect things. So that's good. But anyway, that's the story behind that. And so here we've done our little, just a little cut to allow us to have a little bit better visualization of the septum. And so I'm going to mark here so you can see where we're going to do our cut. You can see there's a little cut there, vertical cut, then a cut going up along the dorsum. Now that cartilage often extends beyond the rhinion, so the bony resection is minimal. In fact, in this one, I just cut a little bit the ethmoid bone. I didn't actually remove any. And I think that's really important that you don't overdo it. In this case, I didn't use an osteotomy to do the cut at the transverse cut at the top. I just used the piezo to go across the top, but you can also use an osteotomy. This is a 4-0 PDS suture going through mucosa, over the rhinion, and then back down through the rhinion into the nose, and then back across mucosa. And the reason I do it that way is because initially I was doing it just through the septum, but it can cheese wire through the cartilage, and you just don't want to do that. So the mucosa gives a little extra strength. It's a PDS suture that's way up high, and the patient doesn't even know it's there, so it just kind of dissolves and goes away. Let's see here. Let me go back. Sorry about that. It just sort of stopped there. Did I stop sharing? Can you see me still?
No, I can still see you. You've got it. Okay, yeah. I think it's the start of the video.
What the issue is, we might have to edit this part, Cameron, because I can't press the advance on the video without hitting
no problem.
Hitting something there. So we'll have to go back here.
It's fine. The first edit was at 28 minutes, and this one's at 44 minutes.
Okay, and so I'm just going to have to let it go back through to that point. It's just another minute or so after that to show the other suture.
That's fine.
Okay?
Yes, it's interesting. I wish I could come and visit you guys. Yeah.
Yeah.
But now they've shut us down. We're not allowed into the States.
Yeah, we for years had so many different visitors from various places spend time with us. In fact, some would spend a year or so with us. But right now, of course, none. We're trying to get someone up from Brazil right now, and she's working on getting okay from Stanford, and she'll have to quarantine for a couple of weeks. But she's going to spend a year doing some clinical observation.
But I'm a few months away from opening my own facility here. 2 theaters, 15 beds.
I want to hear about that.
It's very exciting. So I want to set up like lots of rhinoplasties and try and get you guys here rather than me necessarily going there.
Yeah, that'd be fun. Yeah. Okay, so we're coming up on that stitch again. So the first stitch is that the stitch at the rhinion, and to me that one's the optional stitch. The one at the tip is more important, but this is that stitch going in again, going transmucosal and up through the rhino just below the bony junction, and then back through the other side. I like to use a larger suture for this just because it's easier to visualize it, passing it through the mucosa into the nose. And so you just kind of take a look at where it is inside there, then get it. Sometimes it's a little harder than that to find it, and then go across and then suture it down. So you just kind of stabilize that area once you get it where you want it. And then what we're going to do now is do the one below. And so this goes through that little segment of the modified subdorsal strip, and then it comes through the caudal segment. We've got that set now. Now, this is another patient that really didn't need any tip work. Now I'm just setting the tip. I like to do this tongue and groove method, and we've written some papers about how to optimize that. I use permanent suture for this. You can see that suture going through the septum. Now it's important to have it go through the medial crura symmetrically so that the amount showing is the same, and you can do this, and sometimes it might take 1 or 2 iterations to get the tip projection and rotation just where you want it. Here I'm doing a medial control suture. This is not going through the septum, but just trying to get that tip just the way I want it without making it too tight. You can see there's extra septum up there, so I'm trimming that down. This is what we talked about earlier. Now we've got that super tip just the way we want it, and we do this additional alar spanning suture just to stabilize it again even further. And so our tip is really well stabilized across there and in just the position we want.
So now, say for example, you're taking off 4 millimeters of the caudal septum. How much bone do you remove to know that you don't want to take out too much bone, you don't want to take too little bone, because you need to get everything dropped down?
In terms of the letdown?
Yes.
So the letdown is pretty consistently 3 millimeters. 2 to 3 millimeters is really all you need to do, because with some exceptions, of course. I mean, if you're doing an asymmetric dorsum, as I'll show you in just a minute, then you're going to want to do it differently on each side. If you have a very high hump and you need to take more, I suppose you could take more, but those I would probably just be really careful with using this method on. 3 millimeters seems to be fine because, again, the bone up top, it sort of rotates. It doesn't drop in as much, so that's going to have contact. And down below, the most important thing is to make sure you're not impacting into the nasal airway. So even if you either have a gap or it overlaps just a tiny bit, that's okay. You just don't want a lot of overlap down into the nose. This is another patient from a couple of years ago who came in, and this is showing again using more structural techniques in the tip than the other ones I've showed you. And so she's got a gentle high curve, very narrow tip, which we kept, and she wants her alar flare reduced. And so what we did for her was the letdown operation. The bony cuts aren't shown on the country there, sorry, but in the tip we used a lateral curl overlay. She's somebody who had a small step at the radix. When I was done, I put a tiny little cartilage graft there, which was fine, and we did alar base reductions. And so here she is, 14 months. Okay, so she has a small irregularity. That's just the residual. And again, this is showing what we talked about earlier, but she's very happy, as you'll see, and she actually looks fantastic. And this is something that, unless you analyze photographs, you wouldn't really notice in real life. You can see the tip stability generated with keeping our tripod techniques intact that we like to use. Her alar base incisions reduced her flare. You can see that on a 3/4 view really nicely. Frontal view, preservation of the dorsal aesthetic lines, tip alar bases are less flared. Base view, very slight asymmetry, but otherwise she's doing well. And these are her schnoz scores pre-op, and here she is post-op. Anything below a 2 is inconsequential essentially. So she's doing great aesthetically and functionally. So we're really happy with how she's doing. But the key thing there is, I think, that tip stability, lateral curl overlay, these types of things we like to do with open structure rhinoplasty, we can still do them. So we don't have to sort of give that all up. And I can still do my open structure rhinoplasty. This is a patient that I showed earlier with a straight deviation to the left. These deviated noses are very difficult, and I always explain to patients, we can't make you 100% straight. We can, make you straighter usually, and we can do other things, but I make sure I don't simulate patients totally straight when I have my consultation with them, because we're just not going to get that. And it's very powerful visually to show that to somebody. And so we're going to do this modified subdorsal strip on this patient and an asymmetric letdown. And so in this case, again, this is not an original idea. I've seen many people talk about this, so I don't know who I should give credit to as an originator of this. But there's a paper published by a completely different group from Turkey about this in facial plastic surgery aesthetic medicine earlier in 2020 as well. This case is from before that. But what we're doing here in cross section is we're taking that Roman arch, just like the Leaning Tower of Pisa, right? We're got a lot of Italian references here. It's off to the side. We want to get it straight. One side of that one wall is too long, so we're going to resect that wall only and drop it into position, as shown there diagrammatically. So this is a video, and so in these cases we actually measure the length, and the key is to get the measurements right. But we kind of put the nasofacial groove, and then we decide what the difference is. So we measure with a ruler, and I can see I need about a 3 millimeter, 4 millimeter resection on the right side and none on the left. So here we are doing our piezo approach. We don't do any ostectomy on the left, but on the right, which is on the left-hand side of the screen, we're going to do an ostectomy. And I think I'm going to slow-mo it here to show the bone coming out in just a minute. And so again, you should do here's the bone coming out. So there's the bone. You can see that pretty decent resection. And then we go ahead and complete the rest of the osteotomies. And then the modified subdorsal strip, which I kind of showed you earlier, I think we can probably skip that because it's a similar idea to what we just showed. And so with the structural preservation, in this case, we use an SEG to try to get the tip a bit straighter, and we did the modified subdorsal strip and asymmetric letdown to shift everything to the right. And so, again, this is the modified subdorsal strip being put down in position, and we have that caudal strut we can suture an SEG to. And this is that same, so we'll skip that. And this is, here she is at 15 months post-operatively, so we're able to get the tip up, we're able to reduce the dorsum. 3/4 view shows a nice angles, still some asymmetry in the front view, but improved overall. And so, this is it's about the same result you'd get. I think you wouldn't get any better than that with any other method that I know of. Sometimes, this patient looked much straighter at 6 months and they get a little drift. I think they're stable here at 15 months. And basically.
But Sam, I want to just stop you for a second here. And these asymmetric, straight asymmetric, often the entire face there's even more difference between the lefts and the rights.
Yeah.
And I think because it's difficult sometimes to get this right. Somebody comes to you, they say, my nose is very skewed. But then you can morph them and show them, if you stitch the rights and the left together, how dramatically different the two sides of their face are.
This is something that's been studied extensively by many people. We're actually in the process of doing a large study looking at over 300 patients, analyzing all their faces with key external landmarks to look for what I call occult mid-face asymmetry, or OMA. And this paper hopefully will get done in the next year or so. But there was some work done on this out of Tehran by some plastic surgeons in Tehran about 10 or 11 years ago, looking at tendencies for the nose to deviate towards the smaller side of the face. And I'm not so sure we're going to find the same thing. So I think we're going to add to that literature. But yeah, it's a big issue. Where do you line the nose up? You think about it, I tell patients you have the upper third of the face, the mid third, and the lower third. They don't always line up. And the nose has to connect the upper to the middle and to the lower. So if your lower third is to the right, your nose is going to have to go that way. Otherwise, it would look strange to make it straight. Never mind the fact that if you move the external nose to be straight on the face, but the piriform aperture is over here, you're going to have nasal obstruction. So it's much more complicated, I think, than many surgeons even realize when they're starting out. But this is this patient's preoperative schnoz scores, and then postoperative doing very well.
Brilliant.
I think this is probably the last case I want to show. Then we'll have a little chat. This is a patient who, in some ways, is not the greatest candidate because she does have a kind of low radix, but she does have a gentle hump. Her main concerns are around a droopy tip, and she wants that to be improved as well as tip form. You can see she has some facial asymmetry. The left ala is a little bit lower than the right. you can see the instability of the tip with smiling there as well. And so in this case, I kind of did a few things. We did do a push down this time because I wanted minimal impaction, and I knew I wasn't going to impact so much that I was going to impact the airway. Tongue and groove, we used mini lateral curl struck grafts, which we'll talk about in a second, which is a technique, modification, of course, of the famous Gunter lateral curl struck grafts to just stabilize the tip and preserve tip cartilages. So we're preserving alar cartilage, an alar spanning suture, and a little bit of a cap graft, and the other types of things we can do with open approach to improve tip contour. And this is this mini lateral curl struck graft, which is about a 1 centimeter graft, placed right underneath that super tip area to stabilize it, straighten it. So you don't remove any cartilage, you don't tension it, but you can straighten it with this. So you can't always do tensioning in patients. And so this is a nice way to do that without impacting the airway with a large graft, and also stabilizes it for when you do tip sutures. It stabilizes that area when it's right under the dome so that you don't get collapse or pinching or bossing. And so here she is at 16 months after dorsal preservation and structural techniques. You can see the stability of the tip. This is a 3/4 view showing a really nice kind of angle there, an oblique view. Frontal view, she still has a slight asymmetry of the mid-dorsum as she had pre-op. But overall, her tip, you can see her tip form is really, really nice. You can see it on the base view, especially without having to tension and really extend the nose. So not everyone wants that. And this again shows the tip form change from that bird's eye view with a nice contour and stability without bosse or anything else. And her preoperative schnoz scores and postoperative schnoz scores. So these are, she's a very, very happy person. So, combining structural preservation and preservation of the osteocartilaginous vault with tip tripod techniques is kind of what I like to do. And it means being able to do all the different things, tongue and groove or whatever, hinge flaps, mini lateral curl struck grafts, lateral curl overlay, SEGs, whatever you like to do, along with your dorsal preservation. And so to me, it's adding another tool to the toolbox. I think if you only do rhinoplasty one way, it's sort of like you have a hammer, everything looks like a nail, and it may not be the optimum way for every patient. And so having this in addition to all the other things that I've learned over the years is something I'm really grateful for, and to the people who've taught me in the past few years. So I'm really thankful about that. And this is just a shout out to my Cambodia team. We're missing them, and we hope to go again next year. And I want to thank you, Cameron, for your time. I mean, having me here on your time this evening for you. And let's chat about preservation a little bit, and we can move on to whatever else you'd like to talk about.
No, I think that talk now should be mandatory to all the residents to learn, and also the guys who've been in the game for a long time. That is brilliant. I'm excited. So I've got one more question for you. What percentage of your surgeries do you use these techniques?
So I think that's a good question. In the first 6 to 8 months, I was very excited, and I was doing it in 80 or 90% of my dorsal hump reductions, which was probably not correct. I mean, I think that they all did fine, but I think that I could have more easily, with less stress, done some of those cases because I picked difficult cases for dorsal preservation. I'm trying to do it now. It ends up being about 40 or 50% of the dorsums that I take down. It seems to me that I'm getting, in my practice, I get a lot of patients with really severe complex septal deviations. And so I do a lot of extracorporeal septoplasty. And I've already published that we can do that really well with Joseph technique. And actually, we did publish a paper with 3 cases where we did it with this. But if you think about it, if you take out the septum and then you do dorsal preservation, this whole thing is just floating around, right? And it's a little bit stressful. And the other aspect of it is you don't have any tension you can place on that to flatten it in that case. You're not suturing it down to anything. So the only cases you can really do it on where you have a complex septal deviation where you need to replace the anterior septum with anterior septal reconstruction are cases where it's a very gentle curve where you're actually just lowering the whole thing down and not flexing it at all. And I think in those cases you can do it. But honestly, I'm not sure what the big advantage is in those. You can do a really nice job with Joseph. And the other thing I want to say is, you see some people talk about the destruction of the dorsum and, all this kind of stuff. I don't like using those terms because, the fact is you can do really nice work with Joseph hump reduction. And if you're really careful with how you recreate the dorsal aesthetic lines, you can get wonderful long-lasting results. And, our paper showed also that the airway is just as well preserved. So I just want to point out that I don't really fall into one category or the other. I think they're both really great. And if they're done well, they both work really well for your patients. And doing things well is the most important thing.
So that was great. So let's talk about evidence-based medicine and rhinoplasty.
Yes. That's another big topic. I think it'd be great. I think that, one of my missions as an academic facial plastic surgeon, I used to joke about with other people back in 2002, 3, 4, when I first started, was I wanted to make the world safe for academic facial plastic surgeons. In other words, we were kind of thought of as the black sheep of the otolaryngology family because we didn't really do good science, and everything was about showing pretty pictures and not really measuring your results. So I think that I'm really grateful that in the past 20 years, a lot of surgeons have picked up on this idea. Both in the private world and in the academic world, and I think that we're moving along. So let me share screen and we'll talk a little bit, huh?
That'd be great.
Okay.
I'm reminded when I went to visit Rod Rowe a couple of years ago, I was so taken by the fact that he's in private and working so hard, and the editor, the PRS, and all this kind of stuff. And the one day I asked him, I said to him, Prof, where do you find time for the academics? So he puts the scalpel down and he looks at me. He says, Cameron, academia is a state of mind. And it was just like so great for me because all of our webinars that we've been running and this podcast and stuff, I'm not in an academic setup. I'm in private practice. And you realize that you need to be doing just as much academia and private practice as you are at a university.
Yeah, I think that's so true, and it is amazing what Rod's been able to do with everything that he's done, and in a lot of ways he sets a standard for many of us to achieve clinically and academically. So yeah, I really appreciate that, and kudos to Miguel, as you know, for starting this evidence-based Telegram group that I'm also one of the board members on, and really appreciate that. And I think that there's a lot of interest out there from surgeons to understand, kind of separate the wheat from the chaff, and understand really the best ways to go forward, especially right now with all of the stuff you hear about preservation or other things like that, and all the Instagram posts and everything. It's so hard to separate reality from what you see out there. And what I want to talk about here is the idea of precision medicine and rhinoplasty, which is separating reality from expectations. And precision medicine is a really hot word right now, at least in the U.S. Hospital world. And it's basically a medical model that proposes that the customization of healthcare and medical decisions, treatments, practices, or products should be tailored to a subgroup of patients instead of a one-drug-fits-all model, or simply tailoring the treatment to the individual characteristics of the patient. Now, if you're like me, you're thinking, well, that's what I've been doing my whole career, and that is true to a certain extent, but I think we can do it better. But when you think about what we're talking about understanding a disease process, measuring an outcome, and then individualizing and fine-tuning our medical treatment to treat that specific problem in any given patient more appropriately. And that it requires us to diagnose better what's going on and to measure our outcomes better. And coming up through the system in the 90s, how did we do that? We showed a picture of a nose before and after, and we said, well, that looks good. I think that it's more than that. And so what does precision medicine mean for rhinoplasty? For example, if I showed you this, if I showed this to a room of rhinoplasty surgeons with all the other photographs, I think probably 25% would clap, 25% would say meh, and 50% would probably be looking at their phones and not even paying attention to the screen anyway. So, how do we really measure what's going on with these patients? And it's more than just aesthetics. as I mentioned earlier, it's about function as well in everybody. So it doesn't matter what I show you on the screen if I don't also show you that this patient can actually breathe well or better if they had a problem before we did the operation. And so, as you know, there's three primary modalities for measurement of nasal obstruction: physical measures, quantitative measurements, rhinomanometry, and so on, PNIF. Now we have computational flow imagery, which really can't be done on a patient-to-patient basis. We have physician-derived measures. Just what do you see when you examine the patient? Is there a grading or severity system for it? And finally, patient-reported outcome measures, or PROMs. And I guess the question I'd ask you is, and anyone who's reading or watching or listening to this, how well do subjective descriptions of nasal obstruction correlate with objective measures of geometry and airflow? What do you think the answer to that is?
I don't think they correlate very well.
Yeah, that's your experience, right?
No.
That's what we see in the clinic every day. And studies have shown that. These generally correlate quite poorly. And we're really not understanding exactly why yet. So this is an image from what I think is a classic study from Lamb and Weaver from 2006, and I was fortunate to be at the University of Washington on faculty when I saw them, publish this study. What we have here on the screen is a graph. On the left side, we have the y-axis showing the nasal obstruction symptom evaluation and nose scale, which is a scale for how bad the obstruction is. Worse is higher, a higher score. And on the bottom, we have nasal peak inspiratory flow, or PNIF. And so higher flow is better towards the right. So you'd expect perhaps that as scores go down, peak flow would go up, something like this, right? Don't you think that would make sense if there was actually good correlation?
Absolutely. So what was the actual result?
Yeah, that's what you'd think, but this is actually not the real data. This is something that I generated for this talk. This is actually the real data. And you can see here that there's actually no correlation. What we're showing here, for those of you who can't see, is an absolute dispersed scatter plot showing there's no correlation between flow of air through the nose and symptoms of nasal obstruction. And the authors looked at this another way as well. So, why is this? Why do these correlate so poorly? The answer is that we do not yet understand clearly the mechanisms for sensation of normal nasal airflow. One of the things which I'm not showing here is that there's a lot of research now in terms of the vestibular mucosa and what sort of nasal sensory receptors exist in there. And it turns out that there are temperature sensors just posterior to the nasal vestibule in the area that you might call the internal valve that are very sensitive to temperature changes and menthol. So menthol actually makes you feel like you can breathe better. So there's this whole idea out there that this temperature flux in that area is very important, and computational flow dynamics is an important way of studying that. This is an example of a patient with complete obstruction of the right side. When you look in the nostril by the septum, which is 90 degrees to where it should be, in an open left side, but can't breathe through the left side, swears up and down that the right side is wide open. So this is just an example from the clinic of what you can see. So because of that, I generally don't personally look at quantitative measurements. Physician-derived measures, grades and severity, I think are important. When you think about the nomenclature for example, external valve collapse, it was any sort of collapse of the nostril, and that was what we were taught on our board exams, and the answer was Batten grafts. And I found them not very useful, and early on in my career, I began thinking about things a little bit differently. And I began to think of things in terms of lateral wall collapse or lateral wall insufficiency, and started talking about this in the early 2000s. And finally, at the request of people, said, why don't you publish this idea? And I did publish this idea of lateral wall insufficiency as a term that we should use back in 2008, finally. And really, I divide the nose up into two zones when I think about this, because they're sort of, you treat these differently, and you think about them differently, and they're different sort of etiologies. Zone 1 collapse is much more common, and it seems to happen with senescence. as we lose bone and ligamentous stability around the piriform aperture. And my preferred way of treating it now is lateral crural strut grafts. You can use bone-anchored sutures or Lateral or other things like that. And rim grafts are used in zone 2 collapse, which is more classic external valve collapse. And they really stabilize it very nicely. And you can see those patients are often have sabbatically oriented cartilages, or they have iatrogenic cause of zone 2 collapse. And so this is an example of how I think, for me, more precisely thinking about what's happening in the nose is important and sort of changes the way I treat things. This is an endoscopic view of what we call zone 1 collapse. And you've probably seen many times as well, Cameron.
Do you ever use turn under and turn over flaps of the lateral crura for this type of problem?
Yes, actually. I didn't get to talk about this in the last session where we were just talking about preservation. The preservation of lateral crura is something that has been around for a while, and actually, I was very fortunate to be on the first one of the first papers on that. Craig Murakami, my mentor, had come up with this idea, and we wrote this paper about it. We thought we were the first to show the turn under flap. If you look it up in 2009 in what was called Archives of Facial Plastic Surgery. But it turned out about 6 months earlier, someone from Turkey had published the same idea. And so we've been doing that. Now, I in terms of stability for lateral wall insufficiency, I'm not so certain that it is useful as placing a lateral crural strut graft or something else that's more stable. I think you have to be careful with that, because if someone has lateral wall insufficiency, it means their cartilage is weak already. And so if you're turning it under, you're not really adding much in terms of in terms of that. So I think that probably wouldn't be my first choice for that reason. So we have a grading system also for lateral wall insufficiency, and we showed in multiple papers that you can stiffen the lateral nasal wall with various techniques and get the grade to go down and their obstructive symptoms to improve. So when I think about anatomic nasal obstruction, I don't think about things the way I think a lot of people do. I think about whether it's dynamic or static and whether it's medial or lateral. So static medial deviation is traditional septal deviation or valve narrowing. Static lateral obstruction is due to medialized nasal bone from fracture or surgery or inferior turbinate hypertrophy. Lateral dynamic obstruction is lateral wall insufficiency. And so I divide it into zones and I decide whether it's responsive to a modified caudal maneuver. And just a moment about this for the surgeons that are out there. I think that one of the biggest mistakes people make with this is that they lateralize the nasal wall and they say this patient is going to do well with the lateral crural strut graft or what have you. But I don't think that's really accurate. I think you're actually going to end up with a lot of patients who don't improve if you do that, because you don't actually lateralize the nasal wall very well with any of these surgeries. You can stabilize it. So if you place a Q-tip in there and you actually just stabilize the wall when they breathe and they feel relief, then they have true dynamic instability that's causing their inability to breathe. And I think that's the best way. And dynamic medial is very rare. I don't know if you have ever seen a floppy septum. I've seen maybe one or two in my career, so I don't think that's an important cause. But that's how I think about nasal obstruction. And that gets us to how, finally, the most important thing, I think, is patient-derived measures, PROMs. And I think this is such a key part of my practice and is being, recommended nationwide in the United States, and we're lucky that our PROM is the one that they're recommending. The nose questionnaire you're familiar with. This was really like a landmark paper when this came out in 2004. It was really the first sort of nasal functional questionnaire, and it's been widely translated, and it's very disease specific. It was done for septoplasty and turbinate reduction patients. But as you know, that's only half of the equation, so it's really inadequate. I used for many years that questionnaire, and the launch of my academic career was in many ways because of it, because I published a lot of papers on outcomes with it. But I found that it was inadequate because it wasn't measuring aesthetics. And the question becomes, how do we measure aesthetic results? And as you know, social perception and surgeon judgment are very important, but I would submit to you that the patient's opinion is the most important. And for that reason, I think proms are the most important way to go. And just a couple of points about some proms that are out there and that have been developed in the past 12, 15 years. The FACE-Q is well validated by Andrea Pusick, General Facial Aesthetic Questionnaire, and there's a rhinoplasty subsection that you can use the FACE-QR, but the validation isn't that strong on it. If you look at what we consider strong validation, the questions are not completely relevant. There's no functional component, and it's kind of long and onerous for use by doctors and patients. The Rhino Questionnaire is something that I developed, and this is the story that I like to tell to my residents and fellows about failure. I wanted to develop a short questionnaire that would cover function and aesthetics, and so we went through the same validation process that was used for the ROE, the Rhinoplasty Outcomes Evaluation from 2000, and we sent this out for review, and it was thoroughly rejected. And the reason is because the validation that we used was frankly outdated, and it wasn't very strong. And, I spoke to people who knew about it because I was very disappointed and upset whenever you have your ego hurt when someone tells you what you did wasn't up to snuff. And they said, look, Sam, if you're going to do something like this that you want everyone to use, it needs to be built on a really solid scientific foundation. Because, you're going to base your research on it for the next decade, and other people are going to be using it. You want what you do to really be accurate psychometrically. And this whole idea of, the level of psychometric validation that you need to really have a useful prom became really ingrained in me. So I went back to the drawing board. Other people have published papers such as this one, which is the Utrecht questionnaire, which is fine. But if you look again at the validation on this, and a lot of it depends on which reviewers you get. The validation on this, it's the same things I was criticized for with the Rhino scale. And not only that, it doesn't really have any nasal specific questions. It's really more about how you feel about your nose, not about structure, particular structure things. And there's no function. So it's really not very useful in terms of a prom for rhinoplasty. And so a prom for rhinoplasty should be validated both functionally and aesthetically, should be very strongly validated for the reasons I just talked about, and easy to use, otherwise no one's going to do it. And so when you think about developing a prom, there has to be a framework where you talk to patients and experts extensively about what the most important issues are. Then you create questions based on that framework, and then you do item reduction based on psychometric evaluation of how those questions field test with hundreds and hundreds of patients, and you reduce the questionnaire down to size. And you have to have someone who knows their psychometrics. So this is the framework we use to develop the schnoz, which we're leading up to. And the most important domains to the patients, it turned out, and physician experts we talked to, were social perception of the nose, which is what the Utrecht questionnaire talks about, nasal obstruction, which was what the nose questionnaire talks about, cosmesis overall, and specific cosmesis of specific areas of the nose. No questionnaire covers all of these. And so we had the benefit of having two very famous people help us with this. Mikhail Saltychev is a world-famous psychometrician, physician who develops outcome measures. And he's in Finland. Just an amazing guy, and just really, really instrumental in this and our subsequent papers on this. John Ioannidis is a very famous outcomes researcher at Stanford who helped us with this as well. And Sami Mubai is the fellow who did this, and he actually did the legwork on getting this done. And so, as you know, there's a functional and an aesthetic domain. And so this initial paper had a lot of validation behind it, more so than any of the other ones that I mentioned. But in addition to that, we did further psychometric evaluation of this and published these. We did what's called item response theory analysis, which was published in JAMA. We did then a paper on confirmatory factor analysis. Now, I can't get into the specific statistical psychometric reasons why, but Mikhail Saltychev was insistent that these were really important to make sure this was very well validated. So we have 3 papers just on validation, and then minimal clinically important difference tells you what the sort of difference in score is that would be important to a patient clinically. The natural history of the scores, which happen over time, has been published and had the correlation with psychiatric screening tools. In other words, the schnoz can actually be a proxy for looking for BDD in patients. And a number of studies that we publish and others now are publishing. I just saw a recent paper from Turkey using the schnoz, just using it to look at various different rhinoplasty techniques, including hump reduction, looking at reductive rhinoplasty, looking at dorsal preservation even. So we're in the process of using it for a lot of different things, and we're very happy that it's been translated into 10 languages plus. Others are on the way, and to me, it's a very important thing as part of your practice. And as I mentioned earlier, I kind of feel like it's such an important part of the practice that I feel uncomfortable walking into a patient's room not having looked at what their scores look like beforehand, because I understand what the problem is in some cases. First of all, whether there's primarily a breathing or an aesthetic issue, and secondly, what specific aspects of the aesthetics are a concern, and postoperatively, you can see how your patients are doing also. So I think it's something that's really important for use by all rhinoplasty surgeons. And
so, Sam, how do people contact you for that?
Well, I've distributed it, and a lot of surgeons have contacted me, and I have surgeons who've contacted me who want to do the translational studies as well. So we've made this open access, so anybody who can grab the journal can just take it. I mean, there's no fee; it's free. So it's there for everyone to use. Do you want to talk a little bit about psychiatric disease in the rhinoplasty patient? Or
yes.
Okay.
Very important.
This is very important. And I'm going to just unskip 2 slides here because I think these are interesting to talk about as well. And then we can go from there. So, as you know, and the incidence of BDD is high. It's known to be high in the plastic surgery population. And in the rhinoplasty population, the literature says it can be up to 43% of patients who come in. So the question is, how do you screen? How do you counsel? Do you give everyone a BDD questionnaire, such as the BDD-QAS, which I believe Filio Lakakis developed, which is very nice. I try not to be too onerous with all the questionnaires I give patients. I wanted to know if we could use the schnoz as a screening tool. And we did a small prospective study looking at this. And, in our study, again, we found about 32% of patients screened positive for BDD on the BDD-QAS. But importantly, the schnoz can be used as a proxy because if you have a high score on questions 5, 6, or 8, it is probably a good idea to then move ahead and give a BDD-QAS questionnaire to see if these patients have BDD. And this is another nice reason to use this. And overall, if your score on sections 5 through 10 is very high in general, you should be kind of careful. And we recently published a study looking just at question number 5, and that if you have a high score on question number 5, in my practice, you're more likely to need a revision. If you score a 0, 1, 2, or 3, I had 0 revisions in patients who scored those when I looked over a 2-year period. So just your mood and self-esteem associated with your nose can be a proxy for potential problems down the line. And
I wish I had this conversation 5 years ago.
I know. And so just another interesting study I just want to talk about. This is a good talking point because we look at the work that's been done in terms of psychiatry and plastic surgery patients, and all of the studies that have been done looked at the percentage of patients with psychiatric disease within the group that come and seek plastic surgery. In other words, people who come to your office, how many of them have psychiatric disease on screening tools? And that's like what I just showed you. But I was interested in the opposite. I was interested in, out of all the patients in the United States, for example, with psychiatric disease, how many of those patients seek plastic surgery in comparison to the general population without psychiatric disease? And so we have access to a database with millions and millions of records of all the insurance claims in the United States with treatments, disease codes, and everything. And so we evaluated 1 million records over about a couple-year period. And we divided these into 2 cohorts. You matched for comorbidities. Cohort 1 with no psychiatric disease and cohort 2 with psychiatric disease. And we, codes like depression and anxiety and BDD and so on. And again, we matched them so that these are equally healthy in every other regard. and looked at the incidence of plastic surgery procedures over a 2-year period afterwards in each group, and then created odds ratios. So in other words, what is your risk, if you will, of undergoing a plastic surgery procedure in group 1 versus group 2? As you might expect, unsurprisingly, if you have a diagnosis of depression, anxiety, BDD, or an eating disorder, or other psychiatric disease, as shown below, you have a much higher odds ratio of seeking a plastic and undergoing a plastic surgery procedure. And if you have BDD, it's the highest. You're 3 times more likely to undergo a plastic surgery procedure over that period than somebody without that diagnosis. So it's another way of looking at it. And you think of it as almost a risk factor for your patients, because you don't want to take patients to the OR that might potentially have complications. And it turns out that these patients also had higher risks of complications afterwards, which doesn't make intuitive sense if they're physically the same, but they seem to have a higher complication rate and revision rate. And so these are all important considerations. And, as I said, we want to know if we can use the schnoz to predict outcomes for our patients in order to more precisely treat them. And I think it's proving to be a valuable tool, and I think we have to be aware of the psychological aspect of our patients that come to see us, as well as the physical aspects, because these are all equally important in their health. And so that's kind of what I wanted to talk about there. So what are the next steps? I think that future directions from a functional point of view it'd be really much better if we could really correlate anatomy and subjective symptoms. And I think defining critical points for surgical intervention and understanding this vestibular temperature reception area and understanding exactly why some patients, symptoms don't correlate with their physical findings is important for us. And it may be that computational flow dynamics is going to be important for us. And aesthetically understanding the keys to create happy patients, because, there's technical aspects, and we talked about it in the last part of the podcast, but communicating with patients more effectively about what you can get with your outcomes, having outcomes questionnaires so you can tell them what severity class they might move from in terms of functional and aesthetic distress, and understanding who's not a good candidate for rhinoplasty surgery or any other surgery is important for us. And thanks again, Cameron, for having me on this podcast, and I look forward to chatting with you about that topic there.
Yes, Sam, hour and a half of just one of the greatest talks I've heard. It's been so good just to, like, you taking your Sunday morning off to talk to us and just share. I really appreciate it. Thank you.
Oh, thank you very much. Thank you. Yeah, it's just been great. Actually, it's fun to share and kind of riff about this stuff because I'm kind of passionate about it, and I know you are too. And hopefully, patients and surgeons will find this interesting.
Well, ladies and gents, that concludes episode 2 of the Rhinoplasty podcast. Thank you so much for Sam for how much he taught us about preservation rhinoplasty, about patient-related outcome measures and evidence-based medicine within rhinoplasty. Also, a major shout out to Medicon for sponsoring this, MedHold, who are the suppliers for Medicon instruments in South Africa. Really appreciate us. Our first month of the Rhinoplasty podcast, and look forward to seeing you guys again next week.